This mnemonic is a way of remembering kind of the key components when you're having a conversation with a child from a motivational interviewing standpoint. The first is to ask open-ended questions, then to affirm what the child is saying, and then to reflective listening. And this is more than just saying, like nodding your head and saying, and repeating back what the child says, but really in motivational interviewing, there are different categories of ways to be reflective, and then summarizing what you've heard in that particular exchange. So it's something that, from a unit-wide perspective, conceivably, if everybody on the unit knew how to speak to children in this standpoint, it would go a long way in helping the children kind of be motivated to change specific behaviors, and then creating a culture that's much more supportive for kids and where they're at than a typical inpatient setting. There are, in your slides, there are some resources for where you could get more information about motivational interviewing. Trauma-informed care, I know you guys have been doing a lot of work in this area, so I'm not going to spend a lot of time on this, but I was impressed from the SIPP report about the learning collaboratives that have been in place and kind of how you're all thinking about how to make the SIPP settings more sensitive to the experiences of trauma that kids have. But basically, you know what trauma-informed care is, but it's really being sensitive to the impact and consequences of trauma, both from a clinical standpoint, but also from an organizational standpoint. These are some of the characteristics that a setting has, or staff would have, if they're doing things in a trauma-informed way. And you can kind of use this slide when you think about your own units to get a gauge of how trauma-informed are your own settings. The sanctuary model is one particular model that a trauma-informed model that has been implemented in inpatient settings, and there is some evidence to support it as a promising practice. And there's a website specifically for the sanctuary model, and then a lot of you probably are familiar with the NCTSN website. It has a lot of other resources for trauma-informed care, and just for trauma and children in general. It's a great website if you haven't seen that. Yeah, we're gonna move pretty quickly through the next slides because we want to get to the heart of the matter, which is, okay, great information, but how am I supposed to do this given all the constraints? That's pretty much the million-dollar question. So trauma-informed care, like I said, I think it's great, the initiative that you have in place, and it seems like it really has legs to it, and that's great to see. There are, of course, a lot of client or patient-specific interventions that have an evidence base. I just want to touch briefly on two that I think are particularly relevant in an inpatient setting. The first is trauma-focused cognitive behavioral therapy, and given that most, I would say, of the children that are on your units have some trauma history, having clinicians on the unit that are trained in this approach would be particularly beneficial. And then the second one that I'm going to touch briefly on is dialectical behavior therapy that's helpful for kids with any self-injury, suicidal, or borderline personality disorder. And it's also been adapted for use with kids with other disorders. But I'm just going to talk about these briefly because we want to get into the thinking about what to do. So TFCBT has been used for kids ages 3 to 18, and it's really, it's for kids who've experienced trauma. And acronyms are big in any type of intervention. Like, there's so many ones to remember, but the one for TFCBT is practice, and the PRAC part of it is sort of the first component, and that includes providing psychoeducation to the child and to the parent about the specific trauma that they've experienced and sort of what trauma does, and then teaching the child and the families or caregivers different skills to help the child deal with the symptoms associated with the trauma. So relaxation, affect modulation, and different cognitive skills to help them deal with the trauma. So that's kind of the foundation. And then we move into the second part of practice, the TIS part, which includes the trauma narrative, in vivo desensitization, working with the parent and the child together, or caregiver, and then enhancing safety and social skills. And if you were to think about remember we talked about the common elements approach, like what's one of the key components of this particular treatment? It's the trauma narrative. If you don't do the trauma narrative when you're doing TFCBT, you're not going to get the outcomes that have been associated with this treatment. So just to give you a sense of what that means, really the trauma narrative is about helping the child kind of talk about what happened and the feelings that they had, and kind of gradually exposing them to that in a way that doesn't overwhelm them, so that they get kind of mastery over the traumatic event that occurred. So if you can think about it, if you think about somebody who has a phobia of bridges, if you were treating that, you would kind of gradually expose them to getting on a bridge in a way, and then teach them skills to cope with the emotions that they feel as they're getting on the bridge, until they feel comfortable enough to drive across the Golden Gate Bridge. It's similar with the trauma narrative. The traumatic event is something that has a huge impact on the child's life, and once it's happened, they don't want to, there's a fear to talk about it or to think about it, because it brings up all sorts of emotions and thoughts. Through the trauma narrative, you're gradually exposing the child to that and helping them to kind of come to terms with it and cope with the emotions that they're feeling. So in TFCBT, the beginning of the treatment, you find out, you get what we call a baseline narrative. You just ask the child what happened. And usually when you get that first narrative, there's not a lot of detail, because again, the child is afraid of kind of talking about it too much, because it's going to bring up all sorts of emotion. So here's an example of a baseline narrative for an 11-year-old child. My uncle came into my room to kiss me goodnight. He pulled down the covers and touched me down there. I felt scared. I pretended I was asleep. When he was done, he left. The next morning, I got up, and my uncle said, "Good morning, how are you?" And I said, "Fine, I went to school." So what do you notice about that description? Is there a lot of detail?
No emotion.
There's no emotion. There's not a lot of emotion. So that was a baseline. And it's normal at baseline that you're not going to get a lot of details or emotion in the narrative. But as you kind of work through TFCBT and talk about the trauma more, the child is able to provide more detail. So this is the same narrative told by the child later on in treatment, and you can notice what the difference is. My uncle came into my room to kiss me goodnight. I felt good. He pulled down the covers and touched me down there on my vagina. I felt scared and dirty and thought, why is he doing this? He's my favorite uncle. I pretended I was asleep. When he was done touching my vagina, he left. The next morning, I got up and my uncle said, "Good morning, how are you?" And I said, "Fine." Inside, I felt scared and I didn't know what to do or say. I went to school. So you can see how much of a difference there is between the baseline and further down, and kind of helping the child get to that point where they can provide more detail and not feel overwhelmed or flooded by the emotions is one of the goals of TFCBT, as well as teaching them kind of skills to deal with the inevitable fact that they are going to have moments where they do feel overwhelmed, and kind of what to do with that. There's a lot of research to support TFCBT. As I said, the family or the caregiver component is critical, but even if there isn't a family member that's going to be involved in treatment, the child still can benefit from it, but the results are stronger if the caregiver is involved. There's the book, and then there's also a free web-based course that you can access to kind of just get an exposure to the model, and it offers credits, CME credit or CEU credits for people who do it. So it's a one way of getting staff to getting staff exposed to it. And then dialectical behavior therapy is the other intervention that could be used on units, again, on an individual basis. This combines cognitive behavioral therapy and acceptance-based interventions. Again, it was originally developed for borderline personality disorder adults who had suicidal behaviors, but it has been adapted for use with adolescents. These are the core skills that DBT focuses on. And really the idea behind DBT is to help patients kind of accept the emotions that they have and who they are and the circumstances that they've gone through, while at the same time changing their maladaptive responses to those situations or emotions. So that's kind of the dialectical piece of it. It's the acceptance and change. And that's done through teaching these skills. The mindfulness is a really critical component of DBT, and learning how to be mindful is something that everybody, including therapists, could benefit from.